believe. We were there in the same place but couldn't meet.
Yeah, unfortunately. You visited the hospital visit? I didn't see you. Were
No,
you
no, no.
there?
I didn't visit the hospital.
Right, but I was there for only a short period. I think about during FIP, and then that's it. I didn't stay longer.
Exactly. I came on the day before the opening ceremony, and I
Hmm.
left on third. So even I didn't spend much of time there. It all went only into the Congress. Beyond that, didn't happen anything.
But congratulations to you. That's a big achievement. Congratulations. And
Thank you.
it's so nice to see a young pharmacist, especially from India, being up the stage. It's very nice.
Thank you.
No,
Thank you.
Indian
Thank you.
continent, yes. Amazing.
I believe we can meet during Montreal.
That will be next year. Yeah, looking forward for that.
Yeah, yeah, yeah. And that next year is, of course, Malaysia.
Ah, yes. Yeah, you must come. Then
Yeah,
we are close
definitely.
by. We are close by you already. It's
Yeah,
like
yeah.
how many hours only from India to here?
So,
You're based in which city? Sorry,
I work in Hyderabad, but I'm based in Chennai.
Chennai. All right.
So it's
Yeah.
just 3.5 hours from here to here.
Yeah, nice, nice. I need to visit India too. I've been hearing a lot about it. I'm yet to visit. See,
You haven't visited?
haven't no, not
Okay.
even once. Yeah, because the whole the job requirement is as such.
Yeah.
But otherwise, you are practicing with the university itself as well now.
Yes, yes. See, my time is more into teaching. That's where.
Hmm, interesting.
But we also have associated with the hospital setup where I do practice, but it's not for longer periods. It's very limited time.
Hmm. And that is in Chennai.
No, Hyderabad, Varangal. It's a place called Varangal, around 100 kilometers from Hyderabad. So that's where.
You're very active in FIP.
Just over last 3 years since Brisbane Congress.
Oh, okay. Oh, you were there in Brisbane as well.
You are there in Brisbane too?
No, unfortunately, I didn't meet it. I was there in Cape Town. Cape Town, I was there.
Okay, Cape Town I was also there.
I think before that was Korea or Turkey. I can't recall already.
Before Brisbane, it was in Sevilla, Spain.
Yeah, Seville. That was after COVID, right? I was supposed to go for that.
Yeah,
I didn't make that as well.
yeah. Immediately after COVID, it was in Sevilla, Spain, then Brisbane, Cape Town, and then.
Otherwise, thank you so much for organizing the webinar.
Oh, that's great. It's you are giving your time. That's important for us.
You teach pharmacoeconomics as well?
I don't teach, but faculty in my department do teach pharmacoeconomics as well. We our course module is designed in a way where we teach pharmacoeconomics as well as epidemiology, pharmacoepidemiology, both together in one
Hmm.
particular course. Yeah.
It's very much interrelated. It comes under public health if you see the
Yes.
larger umbrella.
Yeah.
I think it's a very dry topic, so you don't see many people talking about pharmacoeconomics and health economics and all this. But otherwise, I was just like I mentioned to you through our communication as well. I did a short paper. It was not published yet. It's on PMJ about the initiatives. It's
Yeah,
quite
yeah.
interesting how India is doing it. So, and different states is involved, and how many percentages they pay, things like this. Quite interesting.
That's a really good scheme, in fact, and it was so economically effective too.
So your faculty is mostly is from locals, or you also have international students there?
We don't have we have very limited international students. From Gulf and other place, we do have international students. Otherwise, we don't have international students. Most of the people are local to Telangana region, Hyderabad and Warangal, this region. So you must plan on visiting India.
Yeah, definitely. Must. Well, once I think because I see the Indian Pharmaceutical Society is very active in FIP right now.
Yeah, we every year we do have around 100 people visiting it. We have four major member organizations are there. So obviously, different member organization has to be represented by different people, right? So there is a good percentage of population that they attend there.
I heard Indian Pharmaceutical Association talk in the morning with Belgium, together with Belgium. I think was
Yeah,
presented
yeah,
by the president,
yeah.
Mr. Mandal, I think.
Subhash Mandal is secretary. Yes.
So it was a quite a good initiative, like what you guys do in terms of publications. I mean,
Yes.
because when we talk about India, India is huge, and
Huge.
how to reach from urban and rural societies, all different societies. How you guys manage a huge organization. It's interesting. I think even for yourself, you speak few languages.
I speak, yeah, Tamil and English is the language, but I can understand and somewhat communicate in Telugu as well, somewhat Hindi too. So
Just languages.
most
Because
of
you're
us are
based,
multilingual. There is
yeah, because Hyderabad is Telugu, and then you said Chennai, Chennai is Tamil. So
Tamil,
yeah,
yeah.
I'm sure you'll enjoy Malaysia as well because we have a lot of, yeah, even for me, I'm the fifth generation over here in Malaysia.
Oh, that's great, great.
We have a lot of local Indian food and good places to visit,
Yeah,
temples, a
I
lot.
have visited Malaysia in 2023. While on the
Nice.
way to Brisbane, I had a long layover, so we were
Okay,
there
nice,
at
nice.
KL.
At Kuala Lumpur only, in
Yeah,
KL, you need to see the different parts of Malaysia.
yes. I'm planning to visit Langkawi for sure. When I come during
Mhm.
27, I think I should
Yeah,
go.
nice, nice. Don't worry, we will host you. Let
Yes.
me know. Because right now I'm based in, even in Malaysia, we have like West Malaysia and East Malaysia.
Okay.
East Malaysia is like near Borneo, Indonesia.
Okay.
So I'm based there right now in Sabah,
Okay. So you're close to Indonesia.
quite close. Quite close.
Okay.
If you see in terms of the map, Sabah is a state close by the Philippines already.
Okay.
So if I take a boat ride for like 1 hour, 2 hours, I'm already in Philippines.
Ah. Okay.
So yeah, the geography is as such. Like India,
Yeah.
right? A huge
It's,
place
it's it's
where
also huge. Yes. Yes.
you have to visit Sabah. Since I'm here,
Yes.
this is
Sweet.
your best chance.
Yeah. And it's visa free for us, so it's even more
Yeah, it's easier. Easier.
easier.
Dr. Praveen, do we start? We have around 24 participants, and I think more will be joining.
Yeah, yeah. We can start. The others will definitely be joining shortly.
Yes. So, good afternoon, everyone. Once again, a very warm welcome to today's webinar on achieving health equity in HEOR, bridging social determinants and advanced equity analytics. I'm Aryaman, a senior fellow in Kalam Institute of Health Technology. Delighted to be your host for this insightful session jointly organized by the Kalam Institute of Health Technology, and which is also a WHO collaborating center for health innovations, by the way, and in collaboration with ISPOR India Telangana chapter. As we all know, health economics and outcomes research, or as we call it HEOR, plays a crucial role in shaping evidence based healthcare decisions. But yet, achieving true health equity requires us to go a step further by addressing the social determinants of health and integrating them into our analytical framework. Today's discussion will explore exactly how these social and analytical dimensions can be bridged to ensure equitable access and outcomes for all. Uh, Actually, Dr. Kavita, who is the Chief Operating Officer of Kalam Institute of Health Technology, was supposed to join us today, but in her absence, she told me to convey her regards to Major Manvikram and Dr. Praveen. And on behalf of her, I will just give a brief overview of what Kalam Institute of Health Technology is all about. So I'll just share my screen. Is my screen visible?
Yes.
Yeah. So Kalam Institute of Health Technology, as I told, is a WHO collaborating center for health innovations, and it aims to facilitate focused research on critical components which are pertaining to medical devices, and it is supported by the Department of Biotechnology. It's named after our late president, Dr. APJ Abdul Kalam, who was a true statesman in his own spirit. And it is a government of India project, again, which is supported by the Department of Biotechnology. And it draws its credibility from the fact that it is situated in one of the world's largest medical device manufacturing zone. Uh, and these are the departments which are there in the Kalam Institute of Health Technology. So we have a clinical research organization. We have the price monitoring and resource unit, which is under the National Pharmaceutical Pricing Authority. We have a Kalam Blood Center. We have our own in-house journal. We help the researchers who are based here with their publications in the International Journal for Health Technology and Innovation. We have an IVD testing center. We have Kalam certification services, and we are one of the regional resource centers for health technology assessment in India, which is under the Department of Health Research. Another very important center that we have is the Center for Market Intelligence and Trade, where we try to estimate the market size for different medical devices in India and provide data-driven insights to anyone who wants to set up a plant regarding any medical device. Few of the global collaborations that we have. First one is the John Briggs Institute from Australia. We are a partner of the University of Washington's START Center, which is the Strategic Analysis and Research Training Unit, along with whom we do many joint research projects. We are a proud partner of the HTAI. We are a WHO collaborating center for health innovations, as I mentioned earlier. We are also in collaboration with the International Agency for Prevention of Blindness and obviously the Professional Society of Health Economics and Outcomes Research. ISPOR and KIHT events in collaboration. So far, we have been expanding outreach with Andhra Pradesh MedTech Zone, Kalam Institute of Health Technology, and 8 regional and student chapters. All the regional chapters are taking part in updating the pharmacoeconomic guidelines and monthly webinars like this. I think this is the 8th webinar and the second last in the series, where we have been continuously organizing these webinars every month. Participation in global health forums and innovation forums. You can see in the picture last year during the World Health Innovation Forum, which was organized in AMTZ, we had Rob Abbott and Robert Selby from ISPOR who were here. These are the topics on which we have conducted the webinars so far, and this is the second last in the series of webinars that we'll be hosting this year. If anyone is interested in learning more about health economics and systematic review, meta-analysis, cost-effective analysis, then we every year we have the International Fellowship on Health Technology Assessment, and for the year 2026 we have it from 10th to 15th of March. For people who are interested, can register for this event. This is another flagship report that Kalam Institute of Health Technology publishes every year. Uh, In India, we import 70% of our medical devices, only 30% of it is manufactured locally. So, this document becomes very important for the manufacturers, the government officials to make informed policy decisions. We have our International Journal of Health Technology and Innovation, the link of which is always available in our website. And the upcoming event that we have is the third World Health Innovation Forum, which is scheduled from 11th to 13th December 2025. There are no registration charges for this forum, and people who are interested can register for it. That's all about Kalam Institute of Health Technology. I'll just stop sharing my screen. Yep. And today for the talk, we are honored to have with us Major Manvikram Singh Gill, Chief Pharmacist Officer at the Armed Forces Hospital, Malaysia. Major Gill brings a wealth of experience in healthcare leadership and equity based health systems. His perspective will help us understand how data driven decision making and social insights can come together to create a fairer and more resilient healthcare system. But before we start, I would also like to invite Dr. Praveen Devanandan, who is the Telangana chapter, ISPOR India Telangana chapter leader and is the head of pharmacy practice department at St. Peter's Institute Pharmaceutical Science, currently serving as an honorary secretary of IPA and the ISPOR Telangana chapter. He is a multiple time awardee by the International Pharmaceutical Federation, receiving several grants. Dr. Praveen, over to you.
Yeah, thank you, Ariman. Thank you for the introduction. At the outset, my special appreciations to Kalam Institute of Health Technology for uh, involving with all the sport chapters in India and ensuring that there is an activity going on regularly. So thank you very much for that. This ISPOR India Telangana chapter has its resident offices at St. Peter's Institute of Pharmaceutical Sciences. We are from Warangal, basically close to Hyderabad in Telangana. At St. Peter's as well as in ISPOR Telangana chapter, we continuously try to work on various aspects of health economics as well as outcome research, health technology assessment, and all these kind of activities. So when Kalam Institute approached me with this particular title, Achieving Health Equity in HEOR, the first person came to my mind is Major Manvikram Singh Gill. I'm really grateful to you, Major MS Gill, for your time and for he's a very active person in international community, and most of his activities, even if you go through his LinkedIn, you can see most of his activity will be towards this health technology assessment and health economics and outcomes research. He's an apt person for this particular topic, and I just asked him whether he can spare his time because he's having a very busy schedule. I know what kind of activities he do. He doesn't even have free time, but still he's always involved in all this work. So thank you so much, Major MS Gill, for your time, and I'm looking forward for this wonderful session. Also, thank you very much, KIST. Let's have a good session today. Thank you.
Thank you, Dr. Praveen and Dr. Aryaman. I've shared my screen as well. Is it visible?
Yes, yes.
Yes. So, to start off the session today, I would like to thank both of you again and to all our people who are attending today. I hope I'm audible and I don't have a very difficult to understand slang because it's just a simple topic that we will be going through today. It's a dry topic. To be very fair, it's a dry topic. If you're not very much interested in health economics or pharmacoeconomics or health technology assessment, but the thing that really I want to emphasize today is on social determinants of health. Which I hear after, I'll just use the acronym SDOH when talking about it. Because when you don't understand SDOH, you can do all kinds of analysis and it's basically meaningless. In terms, you can be a patient, you can be a payer, or in terms of a provider as well. So when you do any sort of analytics, you need to include SDOH inside because and you need to create equality and equity in providing the best outcomes. So, just a little bit about myself, why I'm very much interested in pharmacoeconomics and health technology assessment. I've been in procurement for about more than 11 years right now. I'm with the armed forces. I practice in Malaysia, fifth generation Indian in Malaysia. So yeah, pretty much I'm looking forward for visiting the Kalam Institute as well, if there is any opportunity. But being in procurement, whenever I manage not only medications but also consumables, reagents, medical waste, vaccines, everything when we do a procurement over here in the Ministry of Defense. And we have our policies over here, and I manage about approximately about 6 to 7 million US dollars if we put it in US dollars. So managing that amount yearly. And for a pharmacist to be doing procurement is not the norm, but when you're in defense, you tend to be, I'll say, wearing many different hats and performing many different tasks. So moving forward, what I'd like to emphasize on today, I'd just like to show a little bit of a scheme that I did when during my readings and literature reviews and as such. When you talk about universal health coverage, you often go deeper into HEOR, health economics and outcome research. And when we focus on HEOR, we then will look into affordability, availability, and accessibility. You see, what I would like to emphasize today is the Asian region, we have 60% of the population throughout the world. And I think with collaborative assessments in terms of pharmacoeconomics and also working together in the region itself, we can actually emphasize better on how to move forward when we look into all of these kind of things. Because as we all know, the geopolitics affects healthcare in general. When we talk about geopolitics, I'm talking about tariffs, assessments, and looking forward in the region itself, we need to bridge together so that we can start using more generics compared to branded. So that's where I can see a collaboration between different countries and even inviting me here today to talk on between Malaysia and India itself. So moving forward, the important terms for today on the presentation I'd like to emphasize on is health equity. We 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 can emphasize the fact that equality doesn't mean equity. So you can provide the equal amount of healthcare to all different patients, but it doesn't necessarily means that all of them will recover in similar sense. We will go deeper into these terms as well because there are health disparities. There's differences in health or determinants of health between populations. Between when we talk about populations, we can even see race, gender, age groups like geriatrics or even pediatrics. There's all difference, and definitely HEOR is a big essence of what we'll be talking today. And like I mentioned earlier, the acronym SDOH is the focus of today because we're talking about social determinants of health. And everything that affects social determinants of health are such like where they born, where they grow, the wages that they get, how much they spend, the expenditure on healthcare, and how the whole healthcare scenario is. And the next one will be on equity informative methods or equity focus HEOR. And DCEA is the tool that we will be we'll be seeing in detail on how it does. And equity weights is when we add on, when we do our assessment, we add this on to see how the outcome is. Because, for example, that we want to introduce a certain new medication or you want to introduce a new policy towards a certain population, you have to balance it up with equity weights. So for urban population, they might perceive it different. For rural population, they might perceive it different. And I'll give examples later on. So we just go through all the terms first and see how differ it is. And for equity efficiency trade-off, we need to see whether it's beneficial for the whole population or not in terms of equity and efficiency. Definitely we want it to be efficient, but sometimes collateral damage has to occur for to prevent inequality. And inclusiveness representative data is important in real world evidence as well. So that's why advanced equity analytics is the whole cycle we can say is required. So when we talk about achieving health equity, bridging social determinants and advanced equity analytics, definitely everyone has to have a fair and just opportunity to attain the full health potential. Because as we all know, healthcare shouldn't be leaving anyone behind. And we go into deeper in HEOR is to provide evidence on value, costs and outcomes. When we talk about cost, it's not just about money. That's why we see value. We need to create the specific value in terms of all-rounded assessment of uh, how the patient will improve rather than just seeing the cost of it. That's why value is not just equals cost. We might be spending a certain amount of it, and HEOR analysis will let us determine whether it's value benefit or not. And for example, I'm not really sure whether the participants are very much exposed to BIA, such as budget impact analysis and DCEA, but I would like to just to give an overview this evening about all these terms as well. So BIA, when you do a budget impact analysis, you're always looking at affordability only. Whether when we purchase this medication, can our hospital afford it to give to the patients for free? Can the patient out of pocket afford it, pay for it? But when we do a DCA, we are also looking at value and fairness. We're also looking whether these patients will benefit in terms of overall preventing inequality. I'll just So when we talk about BIA, the output is always cost flow. But when we talk about DCA, the output will be in terms of ISA and in terms of equity weighted. So equity focus for BIA is not focused, and we talk about DCA is actually explicitly focused on aspect of equity. So to start off again, in terms of my introduction and framing, the objective for today is actually to explore integration of health equity into HEOR. How we integrate health equity into HEOR, taking into consideration SDOH, social determinants of health. The key question is, how can HEOR support equitable access in Asia? I'm focusing into Asia category. I have three different case studies. We'll look into that. And the relevance is because there's growing disparities despite economic growth. For example, when we talk about Malaysia, there's two different regions. There's West Malaysia and East Malaysia. And 60% of the land mass of Malaysia is in actually East Malaysia, but 40% population lives here. So there is a huge gap in terms of urban and rural society. Likewise, sorry. So likewise, in India itself, the region is so huge and we don't want disparity to occur within the whole population. This is whole a public health issue. We want to reduce the inequality among the population. We want everyone to get equal opportunity. So that's why social determinants of health is important to be included to HEOR analysis. So defining health equity in HEOR is an absence of unfair avoidable health differences, and the role is to generate evidence for value-based access. In traditional limitation, it averagesly hides certain subgroups inequalities, like I mentioned earlier, whether they are disabled, whether they are geriatrics, and we even have some frameworks already in place, such as WHO equity, and you have social determinants of health framework by WHO as well, and even ISPO PCORE, which is our patient-centered outcomes research good practices, which we can look into in detail if the participants are interested. So talking about social determinants of health in Asia, since like I mentioned earlier, the income inequality is still considered quite huge. When you talk about income inequality, you can use certain index parameters such as Gini index to look into how much variabilities are there between two different groups. Like we often see when we often see certain disparities do occur. For example, let me give you a case scenario. When we introduce SMBGs, the monitoring blood glucose patches in a population in Malaysia. Only a certain population get more accessible towards it. The population that can afford it. How about the rural population? They can't access it better. So in terms of education and literacy, it definitely impacts adherence and awareness as well. Someone much more adherent will be much more educated or literate about his medications. Even when we look into certain medications packaging, it's the product information leaflet often is in either in English or sometimes in your national language. But all these kind of scenarios do impact adherence as well. And when we are talking about access right now, unequal insurance coverage, that is a huge problem in certain countries such in Asia, when I talk about Asia countries that are is affected by insurance coverage, I'm also talking not only about Malaysia, but even in Thailand, Indonesia, and also Singapore, because I've done numerous case studies involving these countries and how the insurance coverage work differently at these countries. You can see. Moving forward, we'll look into like gender, culture, race, religion, women, and disabled populations are certainly affected as in social determinants of health in Asia. Because, for instance, certain women are not accessible towards oral contraceptive pills in Malaysia, in rural societies. So to reduce all this gap, when we want to introduce a product or we want to provide as a payer, you need to take into considerations. Like I mentioned earlier, social determinants of health, we can look into all these different main. Uh, can we rub off the? I think someone had a yellow drawing over there. I hope so. It's not affecting the slide. Everyone is still can view it clearly. So when we're talking about economic stability, we're talking about neighborhood and physical environment in terms of education, like I mentioned earlier, literacy, language, higher education as well. In terms of food also, community and society context, your integration, and your healthcare system, how the healthcare provide coverage, whether it's covered by the government, whether they have to go to the private, or whether do they have insurance coverage that will provide it for their healthcare, or whether it's just plain out of pocket. And if they can't afford it, and then that's where you get a non-adherent patient. And to talk about advanced equity analytics in HEOR now, let's look into specifically the DCA model. So when we look into the distributional cost effectiveness analysis, it takes into consideration the efficiency and equity, both of it. So you can consider it as a plane where you can have a win-win situation, win-lose situation, or either lose situation. We definitely don't want a lose situation whereby you provide more, you use more costs, but also is unequal, is inequity. So rather than that, we want something that is less in cost, but is in, providing equity as well. So that's where you got your EIA as well, equity impact assessment as a distributional outcome. You got your MCDA, which is your multiple criteria decision analysis, and it includes equity in decisions. Like I mentioned earlier, all the social determinants of health, such as race, age, gender, geopolitics, where they come from, where their location is, all this sort of demographics does affect your HEOR outcomes. And for this data, how do you get it? It's through real world evidence, through claims from your insurance, through electronic healthcare records, through your socio-economic studies. That's why very important. I was just speaking to Dr. Praveen earlier about the usage of epidemiology and public health in HEOR. So it's very much related as well in our health economics. So to integrate DCA into payer decision pathway, this is the main gist of the whole presentation, I think, today. How do you do it? Basically, just putting it on a general scale. We can do workshops later on, or if there's other opportunities whatsoever. So step one, define the equity question. Look into which population you want to target. For example, like you want to target a certain medication or certain consumable for women, or you want to target a certain race or certain race that is staying in a rural society which speaks a certain languages. You want to target this population. So you identify your priorities that is causing the inequality in the first place, because we have to uh, we have to accept that not everyone gets the same amount of healthcare that they need. Some get better, some get worse. So, as public health specialists or as a procurement specialist, or even in terms of introducing your item to the market, you have to know which are your priority, who are your priority. So that's where you identify them, your awesome group. And you collect the equity relevant data, such as baseline health. What is their healthcare right now? What is their BP measurement? All these kind of baseline criteria. What is their HbA1c if you're introducing a type 2 DM drug? So, and you talk into the intervention impact in terms of the cost. So, for example, when we talk about type 2 DM, in Malaysia, one in five uh, are actually affected by type 2 diabetes mellitus because our overweight and obese is quite high over here. So about 1 in 2 Malaysians are actually overweight. So for example, if you're introducing a GLP drug over here to GLP-RA drug, GLP-1 RA drug to reduce weight. So we need to see which population are we targeting, which population that can afford this medication. Or for example, if they're injectable, it needs to be stored in fridge, for example, a cold chain item. So we need to see all these kind of social determinants of health, which the person can access towards it. Because it goes back into the three main things that I mentioned earlier of availability, accessibility, and affordability. And then you run your analysis in terms of your standard CEA, cost effectiveness analysis. But like I mentioned earlier, when you're talking about equity, DCEA is much more accurate because it's subgroups, distribution, and inequality indices are there. So it's equity weighted outcome. And you interpret it then. You compare with your aggregated ISA and your equity weighted ISA. So you can see whether it's equals to 1. Equals to 1, that means it's good. All right, either it's more than 1 or either less than 1. And you assess the change, inequality, visualize efficiency, equity frontier. And then you can develop a decision framework. If win-win, you approve it. That means less cost and equity. So then definitely you want to prove it as a public health or it depends. And then now we are talking about it depends your role in doing this whole assessment, whether as a public health specialist or you want to introduce a policy into the healthcare or in terms of introducing your item into the market. It depends whether you are a payer, provider, or just a society. Depends on which different perspective you want to look at it. And if trade-off, so trade-off is a whole huge big topic, and then we can go into when we talk about HEOR, definitely trade-offs come into play because if you want something, collateral damage is definitely over there. So, for example, you want to introduce a new drug into the market, the trade-off will be that certain older medications you might want, and you are the sole provider for the older medications as well. So you might want to restructure your organization, focusing into a newer item and reduce a portion of your older item over there. So that's a sort of trade-off. You reduce the cost for the older items and you focus into your newer product. And like I mentioned earlier, if trade-off apply weights or negotiated targeted programs, if inequitable, reject or redesign your delivery, how you want to deliver it into the society. What are your social determinants of health that you're focusing on? So the main question is always go back to define the equity question. You need to know which is the population that you're targeting. And then the step 6, policy action. When I'm talking about this policy action, it's not necessarily that means you come from a healthcare decision maker background. You can be even in hospital, you can even be in state level or even national level. It can be in different levels. So for example, in hospital level, what I do is I do all this as a procurement specialist. When I do a purchasing or what, I do apply all this and then I see whether I want to purchase that medication or not for the hospital. That's how I implement all this. For example, if you're in the market, pharmaceutical market, you can implement all this and see whether how do you introduce a new item into the market. So DCEA will get your item across towards certain targeted populations, providing that you can also show the numerical figures to the payers. Either is out of pocket or either is using the healthcare funding from government. So it depends. And step 7, reporting. Document your assumptions, equity preference, and stakeholder inputs. Include your sensitivity and uncertainty as well. So for example, now we're looking into 3 different case studies I would like to speak on. The first one is on insulin. So the challenge is diabetes prevalence, like I mentioned earlier, is quite high over here, and there's affordability gaps because we can look into either whether it's analogs or either it's a human insulin. So, for example, in the military population over here, if let's say either he's ex-service veteran or what, we still will try to provide analogs for the patient because we want to reduce cases of hypoglycemia, things as such, and it's more for ease to use. So for all this, we did our DCEA and we look into all the parameters, all the cost-related parameters. We considered the trade-offs that we have to do in terms of cost as well, and we did implement it using analogs. In the social determinants of health, we got to look into the urban and rural disparity as well. the income inequality as well. We need to see whether for example, in my scenario, whether the government can pay for this or not. And if, for instance, if you're looking into the patient, whether the patient can afford this medication or not, what pricing to place the insulin. So you have to see whether this population that you're targeting, they can pay for that item or not. Whether the out of pocket is it doesn't reach catastrophe levels. Catastrophe healthcare expenditure is a whole other topic, but I have to mention a little bit about it because we are going part by part of it. So in HEOR, DCA shows subsidizing human insulin will yield equitable QALYs, your quality of life years. So for example, we subsidize this insulin for our patients using certain analogs for their convenience. It will generate a public health that will live longer, pay tax, and help the whole society. So we are not looking into short term, we're looking into a very long term over here. And to put the whole product across over there and how it can generate income for the nation back. So it's like investing a little bit right now, but the nation will get the returns later on. This is all the analysis that matters. And the outcome is we do tiered reimbursement. We can do community supply chains as well. Because the supply chain is a whole another huge topic which is needed to mention over here when you're talking about social determinants of health because of the whole urban rural society gap like I mentioned earlier. So this is a case that actually happened with affected us over here in the national armed forces and how we provided analogs for our patients, insulin. Second case what I want to talk about is trastuzumab. So this is a different case when we are talking about high cost limits, but still low income access. People who are low income don't have access to it. So in terms of income and geography, it's a social determinant of health issue. And using HEOR, we did equity weights. We stratified the cost effectiveness analysis by region to see whether rather than bringing in all the branded, we start using generics. We support biosimilars. And we started assistance programs. For example, like they need this medication for a total duration of certain number of years. They can purchase it for like here. And then guess like buy one, free one, something like this. How you program the whole mechanism, the whole mechanism to provide healthcare for the patient. So in this case study, for example, it happened over here, and what we did was we introduced generics for these items, and we also did assistance program for these patients. So, for example, like the patient had to pay 6 for out of pocket, and he get 6 FOC in this scenario. So this is actually a case whereby it demonstrates the policy impact of integrating equity into CEO. So how we integrated equity to ensure that everyone is accessible to the item. The third one is very much, I think everyone is aware of the whole COVID-19 vaccines, about the whole access issue. So the same thing, we had an issue over here of geographic supply inequity. Because like I mentioned earlier, Malaysia is broken down into West and East Malaysia. And West Malaysia, everything is accessible. The capital is over there, everything. And East Malaysia, we have a rural society that are inaccessible to healthcare in terms of geography area is quite a distance, and in terms of it's a hurdle. We'll consider it as a hurdle because when you want to talk about access of healthcare, we will talk about how many kilometers that a clinic is available, a pharmacy is available, where he can go and take a government clinic or pharmacy is available, where the patient just can go over there, pick up the medications free of charge. Nothing. But in terms of getting the vaccines across East Malaysia region, it was a challenge because of the geographical remote islands and transport barriers. So in terms of how we overcome this issue was we did a geospatial DCA analysis in the armed forces because we can get access towards a geospatial analysis of where does population live, how many kilometers there is a region of a clinic or a pharmacy, how do we use all these available resources to reach the patients and provide vaccines for them. I think similar we can do across the whole world how COVID-19 vaccines reach out how it was provided towards the whole bigger population. So it actually improved coverage in vulnerable population. Definitely, it was not cheap. Cost was involved. But in this instance, in this example, we can see that equity was gained, although efficiency was lost because cost is affected, the cost is there. But at the same time, equity is gained. So it's reasonable to do so. Like I mentioned earlier, it has to be in a four quadrant plane. So win-win is low cost and equity. But in this instance, whereby you lose in terms of cost, but you win in terms of equity. So looking at the whole scenario, if let's say you can still afford it, your whole analysis can still afford. You do analysis and your government or the payer can still afford it, whether it's out of pocket. In these instances, COVID-19 vaccine is the government obviously paying for it, whether it still can be affordable, and then we'll still go ahead with it because we want to provide equity. So that's why it's important to look into all the social determinants of health in doing your analysis. Right? And how all this can actually assist in terms of the public health for the whole nation and countries across the regions, across Asia, across Malaysia, India, what's all the different countries is policy and practice implications. So when you incorporate equity metrics in HDA, it's best because your policy is now inclusive and you use DCE. So most people will only use BIA. That's all. You're supposed to use DCA as well or EIA in payer decisions. That's where your government will say that, okay, it's okay to spend a certain amount right now, but to see the outcome later on, to see that everyone is accessible to healthcare. And for this, you need to leverage your real world evidence for equity detection. And it's not necessary this real world evidence comes only from your own country. You can also use RWE from other countries as well. So most analysis, what I do over here is I take from Nordic countries, Nordic regions such as Denmark, Sweden, all these sort of countries because their healthcare equity is much more balanced over there because their taxation is higher. So it depends on the whole healthcare scenario of the country as well, how healthcare is being provided. For instance, in Malaysia, it's a two-tier system, either by government or either by private or a pocket. And right now, since I'm working in the government, so I have to look in a country, I have to take my evidence from a country that is being provided by the government and how much do they spend on it and whether the efficiency is there or not with equity. So that's how you design program targeting social determinants of health. So in terms of conclusion, concluding everything and a call to action for everyone hearing today. So the most important thing I would like to emphasize today on HEOR, health economic and outcome research must evolve from efficiency, looking at cost only. I don't like to use the word cost as well. I always like to say value because cost is just dollars, but value, the value out of it is much more important from efficiency to equity. So everyone from rural to urban, different genders, different community, different language, different people from different regions, whether they might be staying in the remote islands or whether they are in the capital, get access to healthcare. That's the most important thing because we all are looking at WHO's universal healthcare coverage estimates. So we measure who benefits, not just how much. We can see in certain populations, look into their social determinants of health, whereby you want to focus on disabled population or whatsoever. Do your DCEA, put your weighted criteria over there, get the outcome, look into the panel, the quadrant, and then you decide it, and then you put the policy into place. The goal is evidence-driven, equitable access. So the most important thing, no patient is left behind. Everyone's get treated with the most beneficial value. That's the most important thing. That will be all from me today. If we have any Q&A, I'm more than happy to answer it.
Thank you so much, Major Gill. That was indeed a very informative session. We have quite a lot of participants. We have 93 participants. So I request that if anyone has any kind of question, you can either ask, unmute and ask, or put the question in the chat box.
I do admit that it's a very dry topic to be talking about health economics in the evening, but I hope so. I gave justice towards the topic. The main whole idea behind today's webinar is, I think, introducing SDOH into the population that I'm speaking to, because we often don't take into consideration the SDOH criteria, like all these different population that we're looking at. We often just blast it across. We think generally, okay, this item we introduce into the market and good enough. So we have to break into different populations as well and create value out of it. That's the whole idea of today's presentation, I think.
Do we have any questions from the participants? Can we have everyone's camera on? Yeah. Can everyone turn on their cameras so that we'll just have a look at how many of them have actually, made sense of what was talked about in the session. In the meanwhile, Major Gill, like in many low and middle income countries, there is a struggle when it comes to data. There are many data gaps in equity analytics. So, what are the strategies that you would recommend for building a robust and context specific data sets in such settings?
When we talk about lower and middle income countries, uh, for instance, Malaysia, we consider it as a upper middle income country. And our healthcare scenario over here in Malaysia, our healthcare environment ecosystem in Malaysia is different than most of other parts of the world. It's very confusing what we do here in Malaysia, I'll admit generally, because you have two tier over here. Either it's government or either it's private. And when we look into private, there's different providers. When we look into government, like I mentioned to you, from Ministry of Defense, from Ministry of Health, all different. So back to your question, into to get the data for to do your analysis, how do you do it? It's very hard to compare head-to-head analysis between different countries. For example, like what I do is recently I was speaking to Dr. Praveen earlier. For example, I was doing a paper on funding in Malaysia, and I actually referred on PMJ India's initiative. I think that helped me a lot in how to put across the data. You see, when we are talking about data, it should be limitless across countries. It's not a head-to-head analysis. You can take some from this country, some from that country, and then you compare it all and see what is best that will apply to your country. Because, for instance, for India, the GDP is huge. Your GDP is top five in the whole world. And for Malaysia, we are like 36, we are lower here. But the PMJ initiative, I think, is so extensively broad and how it has reached to the public population that I want to take that model and try to implement it in our community over here. So it's interesting how we try to jive with what data that we have, and then we put it into our context, and we we try to implement it over here. So that's why I put today's topic in to focus on APAC region, Asia Pacific region, because I think when we talk about Asia, we have commonalities, we have a lot of similarities. When certain analysis I do take from Nordic countries, but I will always see Asian countries first. I always look into Southeast Asia, whether Singapore, Thailand, Indonesia, Malaysia, we have something in common, and then I'll start going a little bit further. So that's how I do my analysis over here. And for me, because why I always look at India itself also, because you're a huge GDP country, manufacturer in terms of pharmaceuticals, and your access towards active ingredients and pharmaceuticals is huge. So, for instance, for a smaller country like my country, we do rely on your country as well. So that's why data from your country is very much relevant for my country as well. So it's geopolitics. It's a huge, big topic. I'm getting very interested talking about this. It's interesting data because data is the new oil. There's no more oil is not oil anymore. Now data is oil. That is so valuable. Yeah. I hope I answered your question, Mr. Aryan.
Definitely, yes. We can keep talking about it, but then yeah, it is interesting. We have one more question in the chat by Dr. Rihanna Mohammed. Uh, if the case studies you presented are available for reading, would be grateful if those could be shared for better understanding for DCEA and other equity analytics.
What I will do is I'll just leave my email over here in the chat. Please reach out to me via email and I'll send it to you because the case studies that I mentioned is specifically towards my practice. So I think I won't share it generally all. Please approach me through email. I will send it out to you. Because this case studies is real world evidence scenario how it affected me in my own practice and how we overcome it. The three different case studies. The analysis is done.
Do we have any other questions from the audience? Dr. Praveen, would you like to say something before we close the session? Give X. I think you can unmute now. Yep.
Yeah, now I'm able to. Yes. No, that was a wonderful session, Major MS Gill. Because the areas you covered, the case studies that you have presented, it gives a what do you call a live approach of what exactly happens. And I think most of the participants who have participated today will also look in your perspective how you have been practicing it and how you have been utilizing it. So that was wonderful, Major Gill, and thank you so much for your time. Also, Aryaman and all, Dr. Kavya from KHT, thank you very much for organizing this and uh, being a constant, what you call, the push that you give for all the chapters, all ISPOL chapters in India. That's something to be appreciated. Looking forward for your December event, the World Innovation Event. So looking forward for that too. To all participants, it's good to see good numbers. 90 plus participants is good. Good to see all those numbers too. Thank you very much to everybody. Thank you, Major MS Gill and all from KHT too.
Thank you.
Yeah, it's a pleasure to always, be a part of such informative sessions, and we look forward to you coming in December for the World Health Innovation Forum. Major Gill, we would also love to have you here in December. I'll share a formal invite with you post this webinar as well. So, as we come to the close of today's enlightening session on achieving health equity in HEOR, bridging social determinants and advanced equity analytics, it's my privilege to deliver the vote of thanks on behalf of Kalam Institute of Health Technology. Uh, Along with our partners, ISPOR India and St. Peter's Institute of Pharmaceutical Sciences, I extend our heartfelt gratitude to Major MS Gill, Chief Pharmacist Officer at the Armed Forces Hospital, Malaysia, for sharing his time, experience, and invaluable insights with us today. Major Gill, your perspective on integrating social determinants into HEOR and using advanced analytics to achieving equitable health outcomes have been both thoughtful, thought provoking, and deeply relevant in today's healthcare challenges. Your words have reminded us that true innovation in health systems lies not just in technology or data, but in the fairness with which healthcare reaches every individual. Thank you, everyone, once again, and we look forward to seeing you in our upcoming sessions and initiatives. Have a great evening ahead. Thank you.
Thank you, everyone.